Thank you, and thanks for that kind introduction, and thank you, Mark, and the organisers for inviting me to present this today. These are my conflicts of interest, and I would also like to acknowledge and thank all those people living with HIV who've participated in clinical trials and cohort studies that have been able to form the evidence base that we use today for treatment and care decisions. So we've come a long way in 40 years. This is the MJA from June 1983. In Australia, we had the Grim Reaper campaign in 1987. All that did was amplify stigma and discrimination, and that persists today. So that really hasn't changed too much. In those days, opportunistic infections abounded. Half the people who were diagnosed with HIV and an opportunistic infection died within 12 months. There was no antiretroviral treatment until the late 80s, and for the younger ones in the room, we couldn't even measure what our antiretroviral treatment was doing because we had no access to viral load testing till almost the mid-90s. But today is different. We have well-tolerated, potent antiretroviral therapy, and that's resulted in increased life expectancy. We've seen a marked reduction in AIDS-related complications, except for those who are diagnosed late, who are unaware of their HIV infection. And despite virological suppression in over 95% of people on treatment, there is this chronic immune activation and inflammation persisting that drives age-associated conditions, or serious non-AIDS events, SNAEs, comorbidities. So we have lifestyle factors, smoking, substance use disorders, chronic inflammation, maybe some toxicity from older antiretroviral drugs persisting, and then we have normal ageing. That gives us a greater prevalence of age-associated conditions. So ageing with HIV is now inevitable, and we need to celebrate that. But the development of age-associated conditions is now likely for people with HIV. And I've listed the sort of age-associated conditions down there on the right-hand side of the slide. Now, the Apple study was done in Australia. It recruited people with HIV and people without HIV. They were all gay or bisexual men, and they were older. They were greater than 55 years. And what I want you to look at, does this have a... No. What I want you to look what I want you to look at is what I've highlighted. So the graph on your left are people without HIV, and if you look at the age group of 60 to 64 years, the dark red bar is people with 3 or more comorbidities. The next bar down is people with 2 or more comorbidities, and the bottom bar is no comorbidities. If you compare people aged 60 to 64, in those without HIV and those with HIV, you can see there's a doubling of the number of comorbidities experienced by those individuals. So, we've managed to markedly reduce the pill burden for antiretroviral drugs down to 1 pill once a day. But now, because of all those comorbidities, patients are taking a different sort of pill burden. They're adding statins, aspirin, metformin, antihypertensives. And not only is there a new kind of pill burden, there's also a new kind of healthcare practice. We can see all of the different age-associated conditions and SNAEs, serious non-AIDS events, that people with HIV are now experiencing, and that we as practitioners need to be aware of. And as I said a couple of years ago, the silver tsunami is on our doorstep. In Victoria, if you look down the 50% line in 2020, 50% of people were over the age of 50. 2030, 6 years away, 75% of people living with HIV will be over the age of 50. So it represents the fastest growing population of people with HIV. So at the Alfred, we developed some comorbidity algorithms for screening and prevention of some of these comorbidities. And the impetus for this started back in 2013, when we knew that cardiovascular disease was double in people with HIV compared to people without HIV. So we did a bit of an audit of our outpatient clinic, and we looked at factors that you need to actually assess cardiovascular risk. You need to know the blood pressure, you need to know smoking status, and you need to know HDL levels, high density lipoprotein levels, or a cholesterol level. They were not very good. As you can see, only 2/3 had any documentation. So we developed some algorithms about who to screen, when to screen, how often to screen. And we had an educational intervention with our clinicians. And then we redid the audit 12 months later. And it was better, it was a lot better. 88% now had blood pressure recorded, 90% smoking status, etc. But despite that, people with high blood pressure documented, there was no treatment initiated for that high blood pressure. And I would hear things like, but I'm an infectious diseases physician and I don't know how to treat blood pressure, which was just awful. So we thought we have to add treatment to our algorithms, because we do know, as was stated a little earlier here, that many people with HIV go to their HIV specialist and don't go to their GP. And they feel more comfortable with their HIV specialist than with their GPs. So the infectious diseases physicians and the immunologists need to learn how to screen, prevent and manage these comorbidities. And we also became aware that the non-HIV specialist GPs weren't aware of the increased risk of comorbidities at perhaps a younger age in people with HIV. So we developed these recommendations guided by best available evidence and experts in the field. We cross-referenced them with international guidelines, and we also looked at general population guidelines, which don't always consider the nuances of HIV. And we now have version 6.1, which was released on the 1st of December 2023. These are the algorithms we currently have. After the ASHM conference, I was asked to do 2 more, which we will do. Each 2 pages only. Busy doctors can't read a guideline that is 10 pages long. It's only 2 pages. They have who to screen, when to screen, how to manage, and when to refer to the specialists. So this is the layout of the algorithms, and I'm not going to go through all of them, but I'll go through the dyslipidemia in HIV just to give you a feel for what they're like. So that we have, it starts with the who to screen, the frequency of screening, how to screen, what tests should you use. We have lipid targets on treatment with a statin. We also include drugs used for dyslipidemia. We've just added a couple more to this in the latest iteration. We have the starting dose, maximum dose, and also drug interactions, things that you need to watch out for people with HIV. We then look at cardiovascular risk. Does the patient meet criteria for high risk? If no, assess the cardiovascular risk. If greater than 5%, it's just the same as criteria for high risk. We give lifestyle advice and suggest modification, and we start a statin. The PLHIV study was a study of statins in about 7,500 people globally. That PLHIV study showed a significant reduction in hard cardiovascular endpoints with the use of a statin in people, well, it was in all people, but particularly in people with greater than 5% risk. So we've now added that into our guidelines. So you start a statin and then you titrate the statin according to target levels. When do you add a second drug? And at the very bottom, when do you refer to the cardiologist to help you manage the dyslipidemia? So we also changed one of the initial pages of the algorithms, which was reducing cardiovascular risk, lifestyle advice, everybody is aware of, smoking cessation. I don't know about New Zealand, but in Victoria, at my hospital, people with HIV still smoke at higher levels than the general population. And then we have, if the 5-year cardiovascular disease risk is greater than 5%, we use the PLHIV study results. But we also consider whether there needs to be a change in antiretroviral therapy. If that individual is on abacavir and has a greater than 5% risk, maybe we should be off abacavir and on another antiretroviral. The same with protease inhibitors. Protease inhibitors can also cause an increase in dyslipidemia. So modification of antiretrovirals as well as statin, as well as lifestyle advice. So that's cardiovascular disease. I'll just go through some of the updates in the guidelines. We have a vaccination recommendations for people with HIV. The HPV vaccine in Australia is only free for those under the age of 26. People who want to have the vaccine over the age of 26, unfortunately, have to pay for it, but it is available on a private prescription. The pneumococcal vaccine, we now prefer Prevnar above the polysaccharide vaccine, but we tend to give a dose of each if the patient has had one or the other. And of course, Shingrix is new in Australia and is recommended for people with HIV over the age of 50 or people with immunodeficiency. Blood pressure monitoring, the thing that started all of this. There's also sections in some of the algorithms to look at secondary causes of high blood pressure, to consider those, how to investigate for those secondary causes. We have targets of therapy. Again, at the very top, who to screen, how often to screen, and how to screen. We've updated the recommended antihypertensives and have dosing ranges as well as comments. Diabetes is another algorithm that's had a few changes because of the availability of new drugs. Again, the same, who to, how often, and how. If we look at pre-diabetes and diabetes, the definitions of those, that'll be very obvious to all of the general practitioners in the room, not so obvious to infectious diseases physicians, but becoming more obvious. So we manage these, when to refer people and who to refer them to with newly diagnosed diabetes, when to refer to endocrinology. And then the management steps on the second page. We still have consider metformin as the initial step, but the reign of metformin is possibly over. I don't know about the New Zealand guidelines, but the Australian guidelines still haven't changed. That there's clear indications for these newer SGLT2 inhibitors or the GLP-1 receptor agonists. So the Americans have changed, we haven't. I'm not sure what is happening in New Zealand. The Australian guidelines actually haven't been reviewed for about 4 years, so I suspect that they're in review at the moment. Kidney injury, of course, is very important because you need to dose adjust some of your antiretrovirals, so we include that in the algorithms. We also include the sorts of screening and how often to screen. Of course, tenofovir disoproxil fumarate is actually quite hard to get in Australia now as part of a combination regimen. The combination pills with tenofovir disoproxil TDF have now been removed, and they're only TAF, emtricitabine and rilpivirine, darunavir, cobicistat, etc. So we've removed a lot of the TDF guidance in these algorithms, but TDF will still be important for places where it remains a very commonly used NRTI. So we look for causes of chronic kidney injury, aggressively manage cardiovascular risk factors, because of course people with chronic kidney injury have a higher risk of cardiovascular disease, and when to refer to a nephrologist. Bone health is the same. Tenofovir disoproxil fumarate has gone from our market, so to speak. So people with HIV are still getting osteoporosis. We have the secondary causes, how to screen for the secondary causes, and the treatments for osteoporosis, including the PBS restrictions. So unfortunately in Australia we can't get a DEXA scan unless you're over the age of 70. You have to pay for it. And also the PBS indications for bisphosphonates are over the age of 70. So they haven't caught up with HIV despite us putting in applications to have DEXA scans for people with HIV considered. We failed with that. So we also have when to refer to endocrinology. For screening and management of sexually transmitted infections, we include the tubes that need to be used and the swabs to actually screen. We have added a small doxypep section. For neurocognitive impairment, this has changed quite a bit. How to screen, it's difficult to know what the best screening method is. I think most people use MOCA at the moment, or MMSE. We recommend referral to an HIV specialist if that individual is on treatment. So that was a very quick run through. So what are we doing with these guidelines or algorithms? So I think it's important that we look at the quality of care that we are providing for people with HIV. And we've developed some dashboards to look at quality of care. We have a dashboard for the whole of the HIV service, and then we have individual dashboards for each doctor in the clinic with their patients on the dashboard. Only that doctor can see their own dashboard. Other doctors can't see other doctors' dashboards, except for me. I can see everybody's. Because if there's an outlier, I'm going to have words. So each dashboard has individual tabs for the different key performance indicators. And I'm just going to quickly show you what it looks like. So this was taken a while ago, but this is the whole of service dashboard. So you can see that 98% are on antiretrovirals, with 96% are suppressed viral load. Green means measured in the last year. Yellow means measured in the last 2 years. Orange, measured ever. Purple, never measured. That's not good. Purple's there. Not good at all. We also have the demographics. You can see the age distribution at our clinic. The median age a couple of years ago was 53. The top 5 countries of birth, those that have excess alcohol use, current smokers, current intravenous drug use. You can see the number that are overweight, have diabetes, coronary artery disease, and the CKD is end-stage kidney disease, not CKD. That's being changed at the moment. So that's the whole service. And then an individual doctor. And at the bottom, very bottom of this slide, you can see demographics, art and viral load, hepatitis B, C, lipids, blood pressure, etc. So for this doctor, 100% on antiretrovirals with 95% suppressed. This doctor's not doing quite so well with hepatitis C testing. Their lipid testing is pretty good. But you can also see that this doctor has a higher median age, seems to see a lot of the older patients, and you can see the gender count, etc. So then this doctor compares their performance against the whole of service performance. So only 57% of the whole of service had lipids tested in the last year, whereas this doctor, 77% were tested. This also tells you, because we got pushback from the doctors, well, 26-year-olds don't need to have lipids done every year. Well, that's correct. So now we're able to say of the 101 patients, 20 did not require lipids testing done annually. So only 81 needed annual lipid testing. So that's the denominator for this key performance indicator. We have the guidelines up on the right, and then of your 101 patients, 81 should have been tested, 62 were tested in the last year. And then you have 4 had an elevated cholesterol at the last test, 2 had risk conditions. Come on, you should be doing testing in these patients. If you look at the tab down the bottom, patient list, this doctor can press that and will find the 62 from 81, 20 odd patients that haven't been tested, the UR number, when they're coming in next to clinic, etc. So that's how we're using it. And really, what we're sort of proposing, that if you don't measure it, you can't improve it. So if you're not aware of the sort of quality of care that's being provided by some of these key performance indicators, we can't improve. So where do we go from here? Well, we need to individualise care and address the priorities of people with HIV. We are now incorporating quality of life assessments into these algorithms, and we're embedding HIV peer support in routine HIV care. Many of the hospitals around Victoria accessed database many years ago and have been asking for a database. So we've developed a Victorian HIV clinical quality registry, a REDCap database. And so all the hospitals who've joined are able to have their own dashboards and look at their own patients and the quality of care that they're providing. And we'll continue to underpin HIV care using best evidence from clinical implementation, social and basic research. So for the community, you need to celebrate ageing. This is fantastic. But you also should be aware that age-associated conditions are more common in people with HIV. And ask your doctor, are you being screened for these conditions? Be proactive. Assess your own risk of fractures and heart attacks. They're the websites, freely available, you can go to and assess it yourself. Very importantly, stop smoking, reduce your alcohol intake, eat healthily and exercise more, and enjoy your senior years. These algorithms, I'm happy to provide them to everyone. That's the website, or that's the web page that you can get them from the Alfred Hospital. But please, if you do use them, please, please, please check the referral guidelines with your local specialists. These were the Alfred specialists that asked for those particular referrals. Also, it's a live document. We update it regularly, so please check for updates. The link will change if there's an update. You'll find that you won't be able to get to it if there is an update. So just contact me. Finally, I need to acknowledge a whole lot of people who have assisted in these guidelines over the last 10 years. And I want to thank them, in particular Anna Pearce, Janine Trevelyan and Sarah Whiting. And I'll finish there.
Well, that was quite impressive and a lot of information. So we do have time for questions if anybody has some questions. Yep, Rose.
Sorry, this isn't a question, but just to say that on the New Zealand STI management guidelines, on the HIV guideline, we do link to their Alfred guidelines. I know they're Australian, but they're kind of a good starting point. There will obviously be differences in referral patterns and some of the drugs and so on. The link is currently broken, I've just noticed, so we do need to update that. But I've taken a screenshot so we can do that. But yeah, so that's you can access them through that. And thank you. I think they're great. Yeah, really, really good. Thanks.
Sorry, I'm curious to know whether you recorded IV drug use. Have you recorded any substance use, in particular, like methamphetamine, opioids? We've seen an increase in synthetic opioids, as you know, ketamine, GHB, meth, which really affects cardiovascular disease. Do you do an assist in your clinic, like Assist Light, or any objective screening tool?
We don't currently have an objective screening tool. We do have good access to addictions, medicine specialists. We're very fortunate in that regard. We also have a clinic close by where we can refer people. And Thorn Harbour Health also, Thorn Harbour Health is the old Victorian AIDS Council. They also have advice and support for people with substance use disorders. We only actually record intravenous drug use as part of the risk algorithm for hepatitis C testing in these algorithms and KPIs. Yeah.
Yeah, just because meth is such a increasing cardiomyopathy here. I don't know, for many of my colleagues in New Zealand, we see an increasing cardiomyopathy in younger populations associated with meth use.
Yeah.
Just a question up the back.
All that assessment.
That's what a lot of my
And if you
colleagues
do-
say.
And if you do put them on, say, metformin or a hypertensive or something like that, and they're not going back to their GP for assessment, I assume that means you'd need to bring them back more regularly. So I'm interested in...
So we do try to encourage our patients to have a GP and to go to their GP. If there are some patients that just will not go to a GP for confidentiality reasons. So if we are starting an antihypertensive, a statin, we will see them more frequently. For stable patients with HIV, it's a 6-monthly visit. I'm fortunate, I have 30 minutes, although my clinic 2 days ago, was 15 minutes. They just put people in between the appointments, which makes it much harder to do everything you need to do. But it's also a journey. You don't have to do everything at every visit. You can actually prioritise what needs to be assessed at each visit. Because we're also doing quality of life, and you want to talk to the patient about why do you feel that life is not great at the moment, and you start those conversations as well. So you're right, it is difficult to fit everything in, but you don't have to do everything at every visit. If you do start drugs, then yes, you need to get people back earlier, and we have the ability to do that. We also have nurses in clinic who can also assist with getting the patient back, measuring their blood pressure in response to the antihypertensive. It doesn't have to be the doctor that does that. So nurse-led reviews is also very important.
Awesome, thank you.
How long did it take you to convince people to do that?
Sorry?
How long did it take you to convince people to do all of this?
So the last iteration took 12 months. And every time we thought we were ready, something else would change. And so the reprieve study came out. We had to go back to the cardiologist. What do you think about this? And do you think 5% is the cutoff? I actually put 5% in our algorithms before DHHS put 5% in theirs, and I was told that I was brave. It turned out to be right.
That's awesome, thank you.